did fourth year last year, so I've passed my finals. And I'm going to be teaching today about asthma, COPD and bronchiectasis. So before we start, I've not got a poll, so if anyone just wants to put answers in the chat, that'd be great. Just an MCQ to start. So which of the following is not characteristic of asthma? So reversible airflow limitation, hyperresponsive airways, alveolar destruction, inflammation of the bronchi and diurnal variation. Rachel, I can't see the chat. Are you able to let me know if anyone?
So you should
hang on, yeah, got it.
Can you see it? Yeah.
Okay. So you guys have all said C, so that's great. So yeah, alveolar destruction is typically COPD, which we'll be coming on to later. Reversible airflow limitation, hyperresponsive airways and inflammation of the bronchi are the sort of classic pathophysiological features of asthma. And then diurnal variation is classically what you'd see with the symptoms, so worsening over night time and better in the day. So about asthma, it's very common. It affects about 12% of people in the UK. I think it's 12% that have got a diagnosis, and then there's more that are suspected as well. It's a chronic inflammatory disorder of the airways, and it's characterised by three main features. So they are reversible airflow limitation, airway hyperresponsiveness, and inflammation of the bronchi, as we said before. And the main causes are, well, generally atopy. You'll see people have eczema, asthma, and hay fever. So this is in atopic individuals, predisposed to all three of those, and it's IgE mediated. That's the most common, but there are a few other causes. So the hygiene hypothesis suggests that if you've got reduced exposure to infectious pathogens in childhood, so you generally come from a more developed country, you might be more likely to have asthma. Some people are also sensitive to aspirin, so when they take that, they get the wheezy symptoms of asthma. There's also occupational asthma, which you need to do the peak flow diaries to work out when this is happening to them, and often exercise-induced asthma, so people's shortness of breath gets worse on exercise. So pathophysiology, so you get airway inflammation and spasm of the bronchi, contributing to an increase in airway resistance. If you inhale an allergen, so in those atopic individuals, this would cause a type 1 hypersensitivity reaction in the airways, releasing IgE antibodies which bind to the mast cells. If you then inhale the allergen again another time, you get mast cell degranulation and histamine release, which lead to smooth muscle contraction and bronchoconstriction of the airways. So then the key in asthma, which is different to COPD, is that it's reversible. So if you give a bronchodilator such as salbutamol, this will open back up the airways. So you'll notice a massive difference in that person between not having the salbutamol and having the salbutamol, whereas COPD wouldn't get that reversibility. So in response to this inflammation, airways lay down fibrous tissue, which over time can result in fixed airway obstruction. So eventually it can become more like COPD where it's fixed, but generally we diagnose it as reversible. So the typical symptoms are a cough, which often worsens at night, so that diurnal variation we talked about, dyspnea or shortness of breath, which often worsens on exertion, chest tightness, so patients will often describe to you that they've got like a tight band around their chest, and often poor sleep because the symptoms are worse at night. And then your classic signs are an expiratory polyphonic wheeze, so that's a wheeze that occurs on expiration and is got multiple different sounds, a prolonged expiratory phase in the breathing cycle, and tachypnea, so you might get increased respiratory rate. And then you also have acute asthma attacks where the normal symptoms worsen and the peak expiratory flow decreases. So another MCQ about the acute attacks. So which of the following is not a feature that would be described as a severe attack? So if you want to pop your answers in the chat, that'd be great. Okay, so someone said B, a couple of people said B, someone said E. So this one is B. So well done, everyone said that. So this is a peak expiratory flow 65% is predicted. If it comes somewhere between 50 and 70, we describe that as moderate, whereas in severe it would be 33 to 50%. So that's a little bit too high to be classed as severe. But the other features are severe. So if they're unable to complete a sentence in one breath, if they've got a respiratory rate over 25, a heart rate over 110, or normal SATs, or SATs over 92. So these are the classifications. So moderate is just a general worsening of symptoms. So when you start thinking that they're developing into attack, the SATs are above 92%, so they're relatively normal. And the peak expiratory flow, as we said, is 50 to 70% of their predicted. And the vital signs would be relatively normal, so you wouldn't be too worried about them. The severe attack, so this is where they stop being able to complete a sentence in a breath. Their heart rate goes up, their respiratory rate goes up. Their SATs are still relatively normal though, but their peak expiratory flow has gone down to 33 to 50% of their predicted. Life-threatening attacks, this is where you want to start being really worried. They have a silent chest, so you wouldn't hear the general wheeze that you'd normally hear. They might be cyanosed, they'd be exhausted because they've been trying really hard to breathe. They'd get confusion, their blood pressure would drop, they'd get poor respiratory effort, their partial pressure of oxygen would go down, their SATs would be below 92%, and their peak expiratory flow would be less than 33% of predicted for them. So you can remember this by 33, or remember most of these, by 33, 92, chest. So 33 is the peak expiratory flow is less than 33, 92 is the SATs below 92, C is cyanosis, H is hypotension, E is exhaustion, S is silent chest, and T is tachycardia, even more so than the severe would be. And then if you're thinking it's near fatal, so this patient's really in trouble, their CO2 starts raising, their partial pressure of CO2, and they start requiring mechanical ventilation. So these patients are going to want to be in ICU. So how are you going to diagnose asthma? So the key investigations are respiratory exam, peak flow, spirometry with that reversibility that we mentioned earlier. You might also want to do a chest X-ray to rule out other lung disease, blood, so immune profiles, ABG, IgE for that atopic nature of it, and FBC. Another test is FeNO, which is fraction of exhaled nitric oxide, a skin prick test, or a histamine challenge test. So which of those you do is dependent on whether you're going to use the SIGN or the NICE guidelines, so I'll go over those in a second. But yeah, in acute asthma, your priorities are going to be your vital signs, your peak flow, and your ABG, because we want to be detecting those classifications we've just talked about. So if you're following the SIGN guidelines, if there's a high probability of asthma from the initial history and exam, you don't investigate, you just trial treatment and you assess their response. If they're responding well to the treatment, then you can say it's asthma without having to investigate. But if it's an older patient, so you might be thinking more like COPD with them, or if your diagnosis is a little bit unclear, then you're going to do spirometry as a first line investigation. So I think it's usually the SIGN guidelines that are generally used, but NICE guidelines may be used in some places, so obviously check your local practice. So NICE guidelines, their first line is FeNO, then the spirometry with reversibility. If they're still uncertain, they do monitoring peak flow for 2 to 4 weeks, so a peak flow diary, and if they're still uncertain, a histamine challenge test to check for that atopic nature. So the spirometry, which is basically the key investigation in both guidelines, this measures the FEV1 and FVC values and allows a ratio to be calculated. So the FEV1 is the volume of air exhaled in the first second when you forcibly expire. The FVC is the total volume exhaled forcibly in that whole breath. And then you can calculate a ratio of the two. So if the ratio is less than 0.7, that's obstructive disease. So obstructive diseases are things like asthma and COPD. this is different to like restrictive disease like pulmonary fibrosis, where the ratio would be higher. So you're looking for that less than 0.7 ratio. Then if you've got that, you then want to do the reversibility to decide whether it's asthma or COPD. So the reversibility, you give the bronchodilator after the first spirometry, then you do spirometry another time. If the FEV1, so it's just FEV1 you're looking at this time, increases by 12% or more, so that's a number to remember, this indicates that the acute airway obstruction has been reversed, so this points towards a diagnosis of asthma. So asthma management, so there's a variety of drugs used, so SABA is the most common, so like salbutamol. These are relaxed bronchial smooth muscle and they're given as a reliever, so these are symptomatic treatment. This is the one that patients will refer to as their blue inhaler, and as we said, a common example is salbutamol. So these are used not on a daily basis, it's just when the patient feels they need it to help their symptoms. So the inhaled corticosteroid has anti-inflammatory properties, so it decreases cytokines and eosinophils. This is used as preventive treatment, so this is the one where they're going to be taking it once or twice a day, every day. And this is the one that patients will refer to as their brown inhaler. Then there's also long-acting beta agonist or LABA. These can be used as an add-on and they also relax bronchial smooth muscle. Montelukast, which is a leukotriene receptor antagonist, again used as an add-on treatment. Theophylline, magnesium, they're used in acute treatment. And then oral steroids, again, you might be given an acute treatment. And Apritropium, which is another type of inhaler that you can give as a nebulizer acutely as well. So these are the sign guidelines for management. So it's referred to as stepwise management, and you basically start every patient with the low dose corticosteroid, inhaled corticosteroid, so the brown inhaler. You also give them all a SABA to be using for their symptoms. So as their first step, you give them this regular low dose brown inhaler. If you're finding that their symptoms are still not being controlled, so they're taking the SABA quite a lot, you then do an add-on therapy. So in adults, that would be a LABA generally is added on, but you carry on taking the inhaled corticosteroid. Then again, if it's not controlled, you can increase the corticosteroid to a higher dose, or you can add that leukotriene receptor antagonist, so Montelukast. If there's still no response, you're then going to consider specialist care and referring them to respiratory. With children, it's slightly different. So you start them with the over 5s, you start them with the same low dose brown inhaler. Under 5s, you start them with leukotriene receptor antagonist, but again, you're still giving them the SABA for their symptoms. So yeah, you can see there that's just slightly different what you add on, depending on whether they're over 5 or under 5. So there, just to check there. So then acute management of asthma. So there's a nice little mnemonic there to remember this. So oxygen, you're going to want to aim for 94 to 98% SATs. Obviously, if the patient's already saturating okay, you don't need to worry about that. But in the severe life-threatening cases, sorry, they're going to be under 92 anyway, so you are going to be thinking about oxygen. Salbutamol, so you give high dose, you usually would give it by a nebulizer, and you can repeat that as much as is necessary. The next step is giving them steroids. So generally you'd give prednisolone 40 milligrams OD for 5 days. If for whatever reason the patient's unable to take oral medication, you might consider IV hydrocortisone instead of the pred. Apritropium are another type of nebulizer given to further dilate the bronchus. And then again, just keep following the steps if there's no improvement. So theophylline next, magnesium next, and then finally you're going to escalate care. So you're going to admit to ICU if all these steps aren't working. So any patient whose asthma attack is classified as life-threatening, so those 3392 chest things we talked about, or near fatal, should be admitted to hospital. And anyone, if they're in the moderate or severe but they're not getting better with these treatments, then you want to admit them as well. And then anyone who's had an asthma attack should receive follow-up care from a respiratory specialist. So another MCQ before we move on to COPD. So which of the following symptoms is least likely to suggest a diagnosis of COPD? So if you just pop your answers in the chat again. Okay, so we've got quite a few people saying D for this one. So that's right. So the least likely symptom here is hemoptysis. So all the others, so shortness of breath on exertion, chronic cough, wheeze, and green sputum are classic COPD symptoms. The hemoptysis you need to be careful with because you might have a similar patient, so an older patient who might be a smoker presenting with a chronic cough. So you might start thinking COPD, but if they start coughing up blood, then you're going to be wanting to rule out lung cancer. So you do need to really watch out for that symptom in someone you might think has COPD initially. So COPD is another type of obstructive respiratory disease, and it's most commonly due to smoking-related lung damage. So we can divide it into chronic bronchitis, which is a clinical term, and that relates to having that chronic productive cough, which they usually have for at least 3 months over 2 consecutive years. And then the emphysema is more of a pathological term, and this is the structural lung changes that occur in COPD. So you've got abnormal airspace enlargement distal to the terminal bronchioles with evidence of alveoli destruction and no obvious fibrosis, and you get characteristic changes on imaging. So 3 million people in the UK are diagnosed and 2 million more are suspected to have COPD, and it results in 130,000 hospitalisations a year, predominantly affects adults over 40. So the most common risk factor is smoking, so it's like 90% of cases you can attribute to smoking, and it's generally smokers with a 15+ pack year history. So if you've got someone presenting with these kind of symptoms and you ask about smoking and they just say they like socially smoke and they've really not got much of a history, you're probably going to want to be thinking something else. So it's that long-term smoking history you're looking for. So you can work out the pack years using the example, using the equation here. So you'd ask the patient how many they smoke a day and how many years they've smoked for, and then work out your pack years. Another risk factor, more rare but might actually result in a younger adult getting COPD, is alpha-1 antitrypsin deficiency, which is a genetic autosomal recessive disorder affecting 1 in 5,000 people in the UK. So yeah, if you're getting these sort of symptoms in a younger adult who's not smoked, you might be thinking that they have this. So the pathophysiology, so we can think about the airways and the alveoli separately here. So in the airways, you get chronic inflammation of the bronchi, referred to as chronic bronchitis, with neutrophilic infiltration, CD8+ T lymphocytes and macrophages. The chronic bronchitis leads to goblet cell hyperplasia, mucus hypersecretion, chronic inflammation and fibrosis, and narrowing of the small airways. So that's the changes that go on in your airways, but your alveoli, you get permanent enlargement of air spaces distal to the terminal bronchiole, which we refer to as emphysema. You get destruction of the lung parenchyma, resulting in a reduced area for gas exchange and chronic hypoxia. And you get loss of elastin, which results in the alveoli collapsing with dilatation and bullae formation. And then some people will also get cor pulmonale, which is like a late stage progression of COPD. So this is where they get impairment of the right ventricle of their heart, secondary to having pulmonary disease. COPD is the most common cause of it, and the chronic hypoxia that you get in COPD causes vasoconstriction of your pulmonary arteries, leading to increased pulmonary artery pressure, and then that's why you get the subsequent right heart failure. So in these patients, when they've especially had it for a long time, you need to be looking for signs of heart failure as well. So the classic symptoms of COPD, so you get chronic cough, which is usually productive, so productive of sputum. It's generally not too much sputum, and it would generally be like white. If it's starting to be an increased amount for that person and it's starting to become yellow or green, that's when you're considering that they might have an infective exacerbation. They'd also have breathlessness on exertion, so they might come complaining of not being able to walk as far as they could without needing to sit down. They will also have a winter bronchitis episode, so they might, when they first are investigated, they might tell you that every winter they get these kind of symptoms. And they would also have a wheeze like an asthma. So the classic signs are dyspnea, pursed lip breathing. So this is a classic type of breathing that you'll see these patients doing, and what they're trying to do there is prevent that alveolar collapse that often occurs. Again, yeah, the wheeze, coarse crackles, loss of cardiac dullness, downward displacement of the liver, and then you'd also be looking for signs of CO2 retention, because a lot of COPD patients are CO2 retainers. So they'd be drowsy, they'd have asterixis, which is the tremor or the CO2 flap that you look for in a respiratory exam, and confusion as well. And then obviously if they progress to that cor pulmonale stage, you'd be looking for those signs of right heart failure as well. Concerning features, so if they get weight loss, hemoptysis, anorexia, chest pain, lymphadenopathy, finger clubbing, or unexplained fatigue, these are kind of signs that you wouldn't really expect in COPD. So you're going to be looking for another cause, such as obviously if they get hemoptysis, lung cancer. So an acute exacerbation, so it's similar features to their chronic stable COPD, but it's just a general worsening for that person. So they'll tell you that this isn't what they'd normally get day to day, and it feels sort of acutely worse. So key signs on examination, they might be pyrexic because it's often an infective exacerbation. They'd have signs of CO2 retention, so those that we just mentioned before. So the drowsiness, the confusion, and the CO2 flap. They'd also be in general respiratory distress, so they'd be using their accessory muscles to breathe. They'd be doing that pursed lip breathing, and they'd be very short of breath. They'd have a productive cough, so increased amount of sputum compared to their normal, and it may have become green or yellow if it's infective as well. And they'll also have crackles and wheeze on respiratory exam. So you'd define how bad their acute exacerbation is by the Mrc Dyspnea scale. So this ranks it from 1 to 5, and the way to remember it is hard, so breathlessness when they're doing hard or strenuous exercise, hill, so when they're hurrying or when they're walking uphill, they're going to be breathless, horizontal, so they're stopping to catch the breath more regularly than their normal when they're just walking on flat, 100, so they need to stop for breath after less than 100 meters of walking or just a few minutes of walking. And then home is the worst one, so they're breathless on minimal activity around their home, so things like walking from one room to the next or getting dressed in the morning. So to investigate COPD, you generally suspect it from a clinical history of the chronic cough, the exertional breathlessness, and generally smoking history. But anyone with suspected COPD should have spirometry to confirm. You'd also do a chest x-ray in a smoker presenting with a chronic cough to rule out lung cancer. Even if they don't have that hemoptysis, anyone with a chronic cough who's a smoker, you want to be ruling out lung cancer as early as you can. So spirometry findings, so again, you'd have that obstructive picture, so your ratio would be less than 0.7 or 70%. And you wouldn't have the reversibility, so when you do that test that you do in asthma where you give the bronchodilator, it's not going to change very much. The FVC may be normal, but it's often reduced because of the air trapping that occurs, and the FEV1 is generally reduced. So management, so it's generally managed in GP, but refer for specialist care in any of the following circumstances. So if you're unsure of the diagnosis, if it's very severe, if they've got that right heart failure, if they've got bullous disease, if the FEV1 is rapidly declining, or you think they might need specialist therapies such as long-term oxygen. Key principles of management, so patient education, obviously important. Smoking cessation, this is the only management for COPD that actually has any prognostic benefit. So you really want to be encouraging smoking cessation services. They also get yearly vaccinations, so influenza and pneumococcus, pulmonary rehab, and then some pharmacotherapy. So how you decide what pharmacotherapy they have, you put them in group A, B, C, or D. So you use the Mrc scale that we've just talked about, and you also use a COPD assessment test or CAT test, which asks them various questions and ranks them either less than 10 or more than 10. So in Group A, they're going to be getting low on the Mrc scale, so only 1 or 2, and they're going to get low on symptoms as well, so less than 10. So for them, you just start with a SABA, and then you evaluate the effect. You might need to add a LAMA if necessary. So long-acting muscarinic antagonist. Group B, so these have the 1 or 2 on the Mrc scale again, but they have high symptoms, so they're scoring 10 plus on the other test. So with these, you give them the LAMA straight away with the SABA, and then if they have further exacerbations, you switch to a combination of a LAMA and a LABA. So that's just an inhaler that's got both in it. Group C, so these are the ones with the higher Mrc score, so they're having those exacerbations more, but their symptoms are generally well controlled. So you give them a SABA and you give them that combination, and then if there's further exacerbations, you try a LABA with corticosteroid combination. And then Group D, so they're worse on both tests, you give either the LAMA combination or the ICS combination, and then if there's further exacerbations, you give a combination of all 3. So there's an inhaler, which is a triple therapy, so it's got LAMA, LABA and ICS. So then acutely, so when people have infective exacerbations, we're going to manage it either in the community or hospital. In hospital, it's going to be because they're either unable to cope at home, they have severe symptoms, they have severe comorbidities, or they've not got very good activity level. They may already be on long-term oxygen, or you may notice chest x-ray changes. Anyone admitted to hospital requires a full set of bloods, chest x-ray, sputum cultures, and blood cultures if they're pyrexial, so if we're thinking infective. But generally your management for an acute exacerbation, so you're going to use oxygen, but you want to be cautious because they're CO2 retainers, or often are. So if a patient is known to be a CO2 retainer, you want to target their SATs to 88 to 92 rather than the usual 94 to 98. So you're going to use the Venturi mask to control the amount of oxygen being given. You can also use a salbutamol nebulizer. So you give 2.5 milligrams back to back until they're settled, and then 4 times daily after that. Apritropium Nebulizer, so you give 500 micrograms initially, and then 2 to 4 times a day after that. Prednisolone, you're going to give 30 milligrams OD for 5 days. So that's your oral steroids. And then antibiotics, so obviously follow your local guidelines, but typical examples for COPD are doxycycline or coamoxiclav. So that's obviously if you find that their exacerbation is infective, so if they're pyrexial. So finally, before we move on to bronchiectasis, there's another MCQ. So what is the most common worldwide cause of bronchiectasis? Is it CF, cystic fibrosis, whooping cough, ciliary dysfunction syndrome, TB, tuberculosis, or congenital abnormalities? So if you want to just pop an answer in the chat again. Okay, so we've got a mixture of A and B in the chat. So CF or whooping cough. Actually, this one is TB. So CF is the most common cause that you would see here because in developed countries, we've got low rates of TB. So cystic fibrosis is generally a more common cause. But worldwide, because of high rates of TB overall, tuberculosis is the most common cause. But all 5 of those are causes of bronchiectasis. So bronchiectasis is irreversible dilatation of the bronchial tree. So it's an obstructive disease which leads to infection and inflammation distal to wherever that obstruction is found. It's generally a complication of other diseases rather than being an actual disease in itself. So causes, as we said before, so cystic fibrosis is the most common cause in developed countries like the UK. Tuberculosis is the most common cause overall worldwide. Whooping cough, so Bordetella pertussis infection. If you've had this like earlier in life, that might result in bronchiectasis in later life. And then ciliary dysfunction syndromes or congenital abnormalities in childhood. So pathophysiology, so the alveolar walls are destroyed and causing fibrosis of the remaining parenchyma. So your obstruction results in dilatation of the airway, resulting in secondary inflammatory changes. Most commonly affects the lower lobes of the lungs, and it might damage the mucociliary transport system of the lungs as well. So it presents with a chronic cough, which is generally worse in the morning and worse on postural changes. You get sputum, which is often described as being foul smelling and may contain some blood as well. They can get finger clubbing, but this is generally in the later stages of the disease, so wouldn't necessarily be there on presentation. They often get recurrent infections. They might get fever and malaise, and in advanced disease, there's just a general decline in their health. So they're going to start getting weight loss, anorexia, low-grade fevers, and that clubbing that we mentioned. So classic signs are coarse crackles. They might have a lung collapse. They might have reduced or absent breath sounds at the points where the obstruction is found, and it can be unilateral or bilateral. So investigations, so you do a sputum sample because they often have infections. The classic bugs that it might have is Pseudomonas, H. influenzae, Staph aureus, Aspergillus, or Mycobacteria. I think Pseudomonas is the most common of those. On the chest X-ray, it would be normal in early disease, but later you might notice some thickened walls and some consolidation. On CT, you would get a classic signet ring appearance, which I've got a picture of on the next slide. And then because in the UK we're looking for CF in these patients, you would do genotype and sweat electrolyte testing to find out if they've got CF, which maybe hasn't been detected as a child. So this is a signet ring sign. So if you can see where the red arrow is, it's got this little ring which effectively looks like a signet ring. So you're looking for those circles that you can see clearly on there. So the management, so treatment isn't curative, so this will be a lifelong disease, but it's aimed at reducing the infections and secretions and preventing complications. So if it wasn't treated, it might lead to things like pneumonia, abscesses, empyema, fibrosis, the cor pulmonale that COPD can lead to as well, and massive hemoptysis. So obviously we're going to want to reduce the risk of all those things. So a key management is postural drainage, which is a physiotherapy technique. So you're going to want involvement of your multidisciplinary team, especially physiotherapists. Antibiotics, so for the infections that they often get. So initially you can try broad spectrum, such as ciprofloxacin. If it's known to be caused by Staph aureus, try flucloxacillin, sorry. If it's known to be Pseudomonas, you can give inhaled or IV ceftazidime. And then also these patients are on 3 times weekly azithromycin as preventative antibiotics to prevent getting these infections as often. Then they can also be on steroids to slow progression of the disease, bronchodilators if they've got any airflow limitation, and then some get surgery, but this is rare, and it's only if there's if their disease is confined to a small area of the lung, that part can be removed. But obviously, if their disease has become widespread, there's not a lot that can be done about that. So these are where I've got my notes from. So yeah, they're all really good for these kind of things. So that's everything. Has anyone got any questions? Yeah, of course. So someone's asked how to, if I can go through how the Mrc scale alters the management for COPD. So I'll just go back and find that. So this is the Mrc scale. So based on people's exacerbations, we can rank them as one of these 5. So if you find that their exacerbations are occurring when they are walking less than 100 meters, for instance, you'd rank them as a 4. Or if their exacerbations are only when they're doing strenuous exercise, so they're okay with walking on flat, they're okay with dressing themselves, they're okay with everything else, but if they try and walk up a hill, they get an exacerbation, then they'd only be a 1. So that's how you rank them, as 1 to 5. And then for the management, if they get 1 or 2, so where they need to be doing quite a lot of exercise before their exacerbations occur, so their disease is not as bad effectively, then they're going to be in the minimal exacerbations section. So they're either going to be group A or B. If they get 3, 4 or 5, so they're getting exacerbations from not doing very much, then they're going to be C or D. And then the CAT test, which I've not got an example of, but it's like a questionnaire that would be asking patients about what their symptoms day to day are like, would give a score of either less than 10 or more than 10. So if it's less than 10 and their exacerbations only occur, say when walking up a hill, so they're only a 1, then they're going to be in group A, so they don't need much treatment. So effectively their disease is not as bad. But if they're higher than 10, but their exacerbations aren't as bad, then they're going to be group B. Vice versa is C, and then D is both are bad effectively. Does that make sense? Well, yeah, I think that's everything, unless anyone else had any more questions.
Perfect. Is that you done, Janie?
Yeah.
Great. Thank you so much. That was a really good session. If anyone does have any extra questions, you can either message Janie or give paramedics a message and we can pass them on as well. I'll just put the feedback survey link in again. If you wouldn't mind filling that out, that's the way that you're going to get the PowerPoint slides, and the recording will be available on YouTube channel as well in around a week's time. Thank you very much for everyone for coming. Our next session is on Saturday and I'll be covering ABGs, respiratory failure and pneumonia. So it should be a short session again, only about 40 minutes, but with some good revision. So thank you very much for coming and have a nice evening, everyone.
Thanks, everyone.